event. And we certainly want you all to have time to ask questions, but we ask that you save those to the end. So Dr. Mershon, his research interest is in the development of novel strategies to overcome resistance to anti-angiogenic agents using syngeneic and xenograft cancer models of renal cell, breast, and colon cancer. And today he's here to talk to us about an update in kidney cancer treatments. So we're very excited to have you here, Doctor. Thank you for your time today, and welcome.
Hi, Scott, I think you need to unmute me.
Oh, we can hear you, sir. Yep.
Yeah, okay, sorry. Good afternoon, ladies and gentlemen. I see some familiar faces and names, so I'm very happy that many of you have been able to make it to this educational webinar about kidney cancer. I'm going to share my screen, and let me know, Scott, if you can see it.
Yes, sir.
Perfect, great. So again, my name is Dr. Jaime Mershon, and I am a faculty member at the Division of Medical Oncology at the Sylvester Comprehensive Cancer Center and the University of Miami School of Medicine. My area of clinical interest is in the treatment of patients with kidney cancer. When I am not seeing patients in the clinic, I am quite busy either in my research laboratory or in the research clinic trying to find cures for patients with kidney cancer. And both my team and myself try to work very hard for all our patients who have kidney cancer to try to find new treatments to either cure the disease or to improve the quality and quantity of life of our kidney cancer patients. So what is kidney cancer? In very, very simple terms, a kidney cancer is a malignant growth that starts in the kidneys. What we can, as we see in the picture, the kidneys are two organs that are bean-shaped and the size of about the fist or a little bit bigger, and they are located in the back of the abdomen in an area called the retroperitoneum. These are incredibly smart and important organs in our body, and they have different important functions to keep us alive and to keep us well. For example, they help clean the body from most of the toxins, both what we eat or what we're exposed to, or even some medication that we take. The kidney removes and eliminates through the urine all the metabolites and the toxins that need to be out of our bodies. In addition to that, the kidneys also help our bodies control vital functions. For example, the kidneys help control the blood pressure. Okay, they help control the balance between the water and the minerals or electrolytes in our body, like the sodium, potassium, calcium, or phosphorus, to basically keep us in a good equilibrium between what we ingest and what we take out. Other functions of the kidneys, which are less common but also very important, are, for example, in the production of red blood cells. Because the kidneys produce a hormone called erythropoietin, and that helps the bone marrow produce red blood cells and prevent anemia. Okay. Now, how does kidney cancer occur? Kidney cancer occurs when the kidney cancer cells start growing out of control, right? And when they start growing out of control, they start growing as a microscopic nodule that cannot be seen or felt, and then with time, could be months or could be years, these very, very small nodules grow and form a tumor in the kidney. So, is there any known cause for kidney cancer? The answer is that there's no particular cause that we can say, oh, kidney cancer is caused by A, B, or C factors. But there are several what we call risk factors that are associated with an increased risk to develop kidney cancer. For example, smoking is an important risk factor. Okay, patients who smoke have a higher chances of developing this disease. Other risk factors include medical conditions like chronic hypertension or high blood pressure, obesity, some diseases of the kidney, for example, a congenital condition called polycystic kidney disease, where the kidneys are full of a fluid-filled cyst that when they grow, they can transform into cancer. Then also there are genetic factors, meaning that there may be hereditary conditions that lead to kidney cancer. And this occurs mostly in patients who have a strong family history where their parents, grandparents, or close relatives have kidney cancer in one part of the family. Kidney cancer also has been associated with exposure to chemicals from different works, for example, cadmium, asbestos, or petroleum byproducts. Kidney cancer in general is an aggressive type of cancer, an aggressive disease, as up to 30% of patients who have even localized disease and have surgery to try to cure them, up to 30% of patients can eventually develop metastasis or disease recurrence. The most common type of kidney cancer is called renal cell carcinoma. And what that means is that the cancer starts in the kidney tissue, right? The kidney has the kidney cells that produce the hormones and help clean the blood, etc. And also the kidney has like the plumbing, which is the tubes that collect the urine in order to eliminate through the bladder, okay? And the renal cell carcinoma is a term that we use for the kidney cancer that starts in the kidney cells. And there are different types of kidney cancer. The most common type is one called clear cell kidney cancer, which occurs in about 75% of all patients with a renal cell carcinoma. Less common types include the papillary renal cell carcinoma, which they're type 1, type 2, and they are about 15% of all the kidney cancer cases. Less common cases of kidney cancer include chromophobe or oncocytoma, and there are many, many other subtypes of kidney cancer that have been identified. And I'm not putting in this figure because there would be too many to count, and there are very, very rare subforms of tumors. For example, translocation kidney cancer or hereditary papillary renal cell carcinoma that have a different biology, different behaviors, and also different treatments. And many of these kidney cancer subtypes have been associated with different genetic mutations and genetic alterations. One of the first things that we do when we see a patient with kidney cancer in our oncology clinic with my team is to determine, once the diagnosis has been made, to determine what the stage, because that will help us determine the extent of the cancer, and then it helps us in part evaluate and assess the patient's prognosis. There are 4 types of kidney cancer. Stage 1 is when the cancer is localized to the kidney and is in general less than 7 centimeters. Stage 2 is when the cancer is above 7 centimeters, right? And also localized to the kidney. Stage 3 kidney cancer is when the cancer starts going beyond the kidney and, for example, starts invading the renal vein, the vein that takes the blood out of the kidney, or lymph nodes in the area of the kidney. Stage 4 kidney cancer is the most advanced form of renal cell carcinoma. And what that means is that the cancer has actually spread and traveled through the blood or through lymph nodes to other organs like the liver, lungs, bones, etc. When I see a patient with kidney cancer, with renal cell carcinoma, and when I start discussing about treatment, I always try to explain how the medications that we propose to give work. And there are two important concepts that I always try to explain patients when I explain how treatments work, because they are very important pathways or mechanisms by which kidney cancer grows and does what it does, which is expands and metastasizes and progresses. One important concept in kidney cancer is that kidney cancer is dependent on blood vessels. It depends on blood vessel formation in order to grow. The kidney cancer cells are the stars, I think, beige in color, right? And what we are seeing here is that when the kidney cancer cells grow, they need nutrition, okay? In order to get the nutrition, what they usually do is they produce several signals, several chemicals to the environment of the tumor cells. And what those signals do is they activate or they stimulate the neighboring blood vessels, the neighboring capillaries, to form new blood vessels in order to feed the tumors. So one of the first concepts that we learn in kidney cancer is that kidney cancer is angiogenesis dependent or dependent on blood vessels. The second important concept in kidney cancer development is basically the fact that the immune system, which normally helps our bodies get rid of bacteria or viruses or any foreign proteins that don't belong in our bodies, and normally they would go and destroy, the kidney cancers and other cancers as well produce other signals, which are signals that block the ability of the immune cells to attack the cancer. So there are two important lines, two important concepts here about kidney cancer progression that are essential in order to understand how the treatments for kidney cancer work, which is one, that kidney cancer depends on blood vessel formation, and second, in kidney cancer, the immune system that normally would destroy the cancer gets inactivated or gets blocked. So thanks to the research that helped us understand these two important concepts, over the last 15 years, since 2005, and just for you to see how old I am, 2005 is when I was starting my career as a medical oncologist, and I actually was one of the, I was a very just out of training. I participated in the study of sunitinib that led to the approval of this drug. And in the first 10 years from 2005 and 2015, most of the new drugs that were approved for kidney cancer targeted the first pathway or the first concept that I explained in kidney cancer, which is that they targeted this blood vessel formation. They targeted angiogenesis with medications like sunitinib or pazopanib or bevacizumab or axitinib. All of these agents, what they do is they block blood vessel formation. And it has been proven that by blocking blood vessel formation in renal cell carcinoma, we can stop growth and sometimes we can induce regressions of the tumors. From 2015 on until now, the second important concept in kidney cancer was exploited in order to develop new treatments, which is the ability of the kidney tumors to block the immune responses or to block the ability of the immune system to attack the cancer. And new drugs and new combinations came and were studied and approved. For example, nivolumab was one of the first new forms of immunotherapy approved for kidney cancer in 2015. Then in 2018 came a combination of ipilimumab and nivolumab, and more recently, other combinations like pembrolizumab and axitinib or avelumab and axitinib were approved. In addition to this, there are many other combinations of immunotherapies, newer immunotherapies, combinations of immunotherapies and other targeted agents that block the angiogenesis are being developed. And I'm sure there will be more options coming soon in the next couple of years for kidney cancer. Another important aspect of kidney cancer management that we evaluate when we see our patient initially, especially in a patient who needs systemic therapy, needs treatment for cancer, is to classify or stratify our patients, okay, to 3 different groups based on clinical characteristics. We call it good risk or favorable risk, intermediate risk, and poor risk. And we calculate that by checking the patient, doing a physical exam, asking them how good they feel, how strong they feel, looking at the several basic laboratories like the hemoglobin, which is the blood cells, calcium, the neutrophil count, the platelets, and then we can determine based on how many factors are positive or not if a patient belongs to the favorable risk, intermediate risk, and poor risk. Why is this important? This is very important in kidney cancer because this, in great part, guides us to determine what the most appropriate first treatment is for the patient. There are many other factors that we consider in order to choose the best treatment, but this classification, depending on several very, very basic and easy to measure clinical factors, help us significantly in trying to determine the initial best treatment. So how do we treat, what is our approach in the management of patients with advanced renal cell carcinoma? And I'm going to focus on advanced or metastatic renal cell carcinoma because this is what I do in my practice mostly. I work with urologists as well, where patients who have earlier stages of kidney cancer, meaning kidney cancer that is localized to the kidney, they usually get surgery to remove the kidney. And if it's early enough and there's no evidence of metastasis upon diagnosis, many patients can get cured from kidney cancer when it is early enough. Okay, and so when patients come with renal cell carcinoma that has progressed or has spread to, let's say, to the lungs or to the bones or to the liver, okay, we use a multidisciplinary approach at Sylvester, where we discuss with our pathologist who is specialized in kidney cancer and can determine what subtype it is. Remember, there are several different subtypes of renal cell carcinoma, the most common of which is clear cell renal cell carcinoma. We also discuss the findings with a radiologist to determine exactly where the lesions are. We do a physical exam and a thorough evaluation of the patient's functions by blood tests and by other tests, like, for example, an echocardiogram to check the heart function, because all of that is going to help us determine if a patient is more fit for one treatment or another, right? An important aspect of the management of kidney cancer is what we call multidisciplinary approach, where we many times discuss our patients with other specialists. For example, as I said, pathology, radiology. Sometimes we discuss our cases with urologists, which are the surgeons who operate on kidney cancer, or specialists in other types of surgery, like liver surgery or lung surgery. And why is that? Because the treatment for kidney cancer is individualized. Every patient is unique. Every patient has a unique tumor, and each tumor requires a unique treatment. We have seen a lot of patients with advanced kidney cancer, and we make recommendations based on several factors. Some of the important factors that we consider to choose a treatment is the patient's overall health. For example, a patient who has no significant medical conditions, like if their heart is okay, they have not had a heart attack, or patients don't have any significant other medical conditions like diabetes or autoimmune disorders, okay, maybe some treatments may be more appropriate than others. We also look at the laboratory results, like the calcium, the hemoglobin, etc., to look at this stratification in good, intermediate, or poor risk. We also determine the tumor behavior. Okay, we try to determine how fast the tumor is growing. Okay, and sometimes patients may come for a second opinion to Sylvester with an older CT scan 3 months ago or 4 months ago, and we usually recommend to have a new scan to determine the pace of growth, because that also will determine what the best treatment is. Also, the number of metastases. Does the patient have only one metastatic lesion, one site where the tumor has spread and nothing else, or there are multiple in different organs? It also depends, and is a very, very important factor, the patient's wishes. Okay, how aggressive the patient wants to be, first. Second, how does the patient, is the patient willing to tolerate one set of side effects versus different side effects, because different treatments have different side effects. And we discussed most of the options and the side effects, the benefits and the risks. And last but not least, a very important aspect is also the doctor's experience and the team's experience. I think this is key and very, very important, because as each kidney cancer is unique and each patient is unique, and the number of treatment options for kidney cancer is so large and is growing, okay, having experience in treating patients with kidney cancer is important to ensure the most appropriate treatment for patients. So what are the options for patients who have advanced kidney cancer? So we will see here a patient with metastatic renal carcinoma. Let's say a patient is doing very well, has, let's say, a mass in the kidney, and has one lung metastasis only and nothing else, right? Has no symptoms, is a good surgery candidate. Sometimes we may recommend to see our surgeon, both a urologist and a thoracic surgeon, to remove the kidney that has the tumor and to remove that single metastasis, okay? Sometimes patients, for example, may have a kidney cancer diagnosed 10 years ago or 12 years ago, and then suddenly they develop a very, very small, or 2 or 3 very small lung nodules that are 4, 5, 6 millimeters, okay, which are growing very, very slowly over the years. So in those patients, one of the options that we discuss is active surveillance or watchful waiting. Why is that? Because those patients whose tumors grow very slowly, and we discover that they have metastases like very long after the initial kidney surgery, they usually belong to what we call the good risk group. The tumors are very slow growing. Sometimes it may take years for them to grow to up to 1 centimeter, okay? So we discuss with these patients the benefits and the risks of a treatment that is available, okay? And sometimes in those patients, we decide with the patient. Obviously, the patient's wishes are very important. Sometimes we recommend not to give any active treatment, but keep following the patients with CT scans every 2 or 3 months, depending on the needs. And if these patients who have very slow growing tumors, very small ones, not causing any symptoms, if after 2 years or 2.5 or 3 years, they grow to a certain level, okay, then we go to systemic therapy, to active treatments. So again, active surveillance is not for everybody. It depends, again, on the patient. It depends on the tumor, usually slow growing tumors that occur years and years after the initial surgery. Patients who do not want to be exposed to side effects to a treatment may be candidates for this active surveillance. And then we have the option of systemic therapy, which is what medical oncologists like me do. As you can see on the right side, there's a very short list of potential treatments. And we can divide the treatments, the systemic therapy for a metastatic renal cell carcinoma, in 2 big groups. One, immunotherapy-based treatments. For example, combinations of immunotherapy like berlizumab and axitinib, which is a targeted agent that blocks blood vessel formation, or avelumab and axitinib, or a combination of 2 immunotherapeutic agents called ipilimumab and nivolumab. All of them are FDA approved for the first-line therapy of patients with metastatic kidney cancer who have certain characteristics, right? Other options include targeted therapies alone, like cabozantinib or sunitinib or pazopanib. We are using less and less the option of single agent targeted therapies alone, because the most recent in the last year, 2 years, suggests that a combination of an immunotherapy with something else may be better. However, there are conditions, some situations where targeted therapies alone are appropriate and patients do well with them. For example, patients who have metastatic renal cell carcinoma and have what we call autoimmune conditions, right? Autoimmune conditions are conditions where the patient's own immune system attack their own bodies, like lupus or arthritis or Crohn's disease, right? The use of immunotherapy agents in patients with autoimmune disorders can significantly increase the patient's risk to make the autoimmune disorders worse. Therefore, patients can have more harm than benefit if we use immunotherapy. It is very rare, but sometimes we have seen patients who have a transplant, organ transplant, like kidney transplant, for example, or a liver transplant, who come with metastatic kidney cancer. Those patients are usually taking immunosuppressive medications to prevent rejection, to decrease the immune response. If we use immunotherapies to activate the immune response, that may represent risk to the transplanted organ, right? And also options for the treatment of patients with metastatic renal cell carcinoma. We at Sylvester have a large number of clinical trials for renal cell carcinoma that are available, and we always discuss the option of clinical trials in our patients. So this is a summary of what is available in terms of standard of care and that is FDA approved for renal cell carcinoma. Okay, I mentioned some of them, and whether we use the targeted agents like sunitinib, pazopanib, or combinations, or more aggressive immunotherapy like ipilimumab or nivolumab, depends on this stratification that we do at the beginning. If patients have good or favorable risk, intermediate or poor risk. And then in red, we have options that we can use if the first option doesn't work. And you can see that the list is large and the list is growing. that is a good thing about kidney cancer. We have a lot of options that are both standard and also investigational that can bring a lot of hope for patients with renal cell carcinoma. So at Sylvester, we always keep clinical trials in mind when we discuss options. Sometimes a clinical trial may be the best option for a patient. Sometimes the standard of care may be the best option for the patient. So no treatment is the same. We cannot generalize and say, you know, this patient who I know with kidney cancer has this treatment, is doing fine, why I'm getting another treatment? It's because each cancer is different and we cannot really replicate the results of one treatment to a different patient. A challenge that we have in the field is the treatment for non-clear cell renal cell carcinoma, like papillary kidney cancer or chromophobe or translocation. Okay? Most of the data that we have is from smaller clinical trials. And many times what we do is we use data from clinical trials in clear cell kidney cancer and apply them to patients with non-clear cell. And again, one of the first options that the experts recommend is to put the patients on clinical trials. We also have options of the targeted therapies like cabozantinib or everolimus, and there are several standard or experimental options that we use frequently in patients with non-clear cell renal cell carcinoma. Another important question that patients ask all the time is like, I had my kidney removed because I had kidney cancer, right? And do I need treatment to prevent tumor recurrence? Okay, I wish I could tell my patients, yes, there is treatment that we can use to prevent recurrence. However, over the last 15 to 20 years, trial after trial, study after study, using from the older agents that we had before to the newer agents, none of them have significantly shown that they are good at preventing recurrence, okay? The newer trials that we are having right now to try to prevent recurrence are using immunotherapy, okay? And they're promising, and we don't know yet whether they will prove to be important in preventing disease recurrence. We have several of these trials here at like the ECOG trial, the InMotion trial, which we're already close to accrual, and we always try to offer these trials in patients who have specific characteristics that put them at high risk of recurrence, and patients may go into a trial. So, in summary, in this part of the talk, in addition to the standard of care that we have and we are expert on, we always also consider clinical trials, because clinical trials are valid options for the management of renal cell cancer. Thanks to clinical research and clinical trials is where the field of kidney cancer has advanced so fast in the last 5 years. We have come together, the investigators who do kidney cancer, to do trials together and to enroll patients who we believe will benefit from a clinical trial, and many patients have benefited. And these experimental agents that were experimental like 4 or 5 years ago, now they are considered standard treatment and FDA approved. Okay, so we talked about the other alternatives like the resection of the primary tumor. Sometimes, as I said, when patients have very, very few, just 1 or 2 metastases in a similar area in the body like the lungs, sometimes we may offer what we call metastatectomy. And we also talked about the active surveillance or watch waiting, which is no treatment and no surgery, but just observing the patients, especially in patients who have low-growing tumors who don't have any symptoms, and if patients feel comfortable with this strategy or with this approach. So now let's go to the future. What is coming up in kidney cancer treatment? You see this very busy slide where you see several cells, several pathways, and what they represent is like each of the cells are different types of immune cells that have different functions in the immune response against the cancer. So there are some good immune cells like the CD8 or T helper lymphocytes, and there are bad immune cells, which are cells that actually block the anti-tumor responses against the cancer. And the new treatments that we and others are investigating actually are targeting different components of these good and bad cells. In this cell here in blue in the center, you can see several proteins in the surface of the cell. Each one of those is a receptor that is a target for new treatments. So they're agents, they're medications, either antibodies or small molecules that are targeting each one of these agents. And just multiply this by the other parts of the figure, which are much more and more variable antigens and targets. You can just imagine how rich the field of research in immunotherapy is and how promising it is, because each of these drugs represents a hope for better cancer control. We at Sylvester have an increasing number of clinical studies for kidney and other cancers that are targeting many of the targets that we're seeing here. Some very, very promising agents that are closer to hopefully becoming a standard of care in kidney cancer are different types of targeted agents. One that is worth mentioning, and that we have clinical trials at UM, is this agent called PT2977 or MK6482. And this is a new class of medication that in the early studies has shown to be very promising and active in patients with kidney cancer, metastatic kidney cancer, who have not responded to prior treatments, either targeted agents or immunotherapeutic agents. So there are several trials of this agent, this drug, that is blocking a very, very critical mechanism, a very critical circuit in kidney cancer that is called hypoxia-inducible factor, that has been associated with good activity in patients with this disease. Okay. Other agents that are on development are agents that block metabolism of the tumors. Okay. This glutamine metabolism is an important pathway by which the tumors bypass the need of sugar, bypass the need of glucose, and they produce energy from proteins or from amino acids. So some agents like CB839 block this important mechanism of producing energy by the tumors, that some of them are actually very dependent. Some tumors are very dependent on this pathway, and they can overcome the need for glucose, all right? One option that is very close to my heart, because this is what I do in part of my basic or laboratory research at Sylvester, is the use of oncolytic viruses for treatment of kidney and other cancers. An oncolytic virus is exactly what it says. It's a virus. It's a viral agent that we and others engineer or re-engineer and train the viruses to attack, more specifically, cancer cells more than normal cells. And then we can give them either intratumor as an injection inside the tumor, or sometimes we can give intravenously, okay? And then the virus, when it goes in the circulation, they go and look for the tumor, they infect the tumor. The viruses, as you know, are very effective at causing infections. So these viruses that are designed to infect only tumor cells, they efficiently infect the tumor, multiplies in the tumors, and tries to kill the tumor. And when doing that, it causes inflammation in the tumor that activates the immune response. So this is a very promising, we have clinical trials using oncolytic viruses for kidney cancer. It's not for everybody, okay? It has very, very strict criteria to enter those studies. And they are available. So we always, when we discuss trials and patients, we always consider these trials. This oncolytic virus trial, for example, is not for first line, but it's for patients who have failed other prior treatments in kidney cancer. So in conclusion, and just to finish, I think we are good in time. I can say that the state of the field in renal cell carcinoma is strong and is very promising. Significant progress has been made in the treatment options for renal cell carcinoma, including immunotherapies and targeted therapies are beneficial and are real options for patients with previously untreated advanced renal cell carcinoma. And that has led to improved prognosis and improved outlook for many patients with this, like a fatal disease. 10 years ago, when I was doing my fellowship, a patient with metastatic renal cell carcinoma, we just had one option, which was interleukin-2 or interferon, which worked in some patients, didn't work in others. And if they didn't respond to that, then we had to say, I'm sorry, there's not much we can offer right now. Okay, but now in 2020, we have many options that are real, are valid, and offer a lot of hope for patients. The immunotherapy strategies have changed. I wouldn't say may change, but have changed the standard of care. Now immunotherapies are considered first-line options and also sometimes second-line options, depending on how you use or what sequence you use in kidney cancer. But there are other very interesting agents and targets, for example, hypoxia-inducible factor, which I think is one of the most promising agents, targeting the tumor metabolism, oncolytic viruses. All of these upcoming agents, upcoming options, really make the field of kidney cancer very promising and offer a lot of hope for patients with this disease. Another important conclusion is that experience counts in managing renal cell carcinoma. And we are very happy to say that at Sylvester, we know how to treat renal cell carcinoma. And it's not only the medical oncologist, it's a whole team that dedicates to renal cell carcinoma. That includes pathologists, radiologists, surgeons, radiation oncologists, and laboratory researchers who are using models of kidney cancer, using kidney cancer cells, and try to get new treatments to cure this disease. The field is not perfect though. There are still needs. We always have pending items or things that need to be improved. Okay? We have so many treatment options, right? Many treatment options. And we need to try to streamline and learn better how to individualize kidney cancer therapies, okay? We will need to keep doing research in identifying better treatments to prevent kidney cancer recurrence after surgery, which is an important problem. Also, we need to develop better therapies for patients with non-clear cell kidney cancers. Those patients are less common. Those cancers are rare. And therefore, because the number of patients is smaller, there is less opportunity to do large research with these patients. Patients with kidney cancer, when it is advanced, still die of progressive refractory disease in some cases. And those are very difficult, both for patients and for the doctors. We love all our patients and we treat our patients as if they were our families, and we suffer with them, okay? We work together and fight together this disease. We are dedicated to kidney cancer, We always try to do the best for the patient. And because some patients still progress and don't respond to treatment, we need to continue making efforts and increasing efforts to discover why kidney cancers develop resistance to treatment and how can we overcome. And this is one of our focus of research at Sylvester in kidney cancer. Okay, all of that is possible only with funding for kidney cancer research. We need more funding. Funding in kidney cancer has been very limited until several years ago. Now it is improving. However, we still need more opportunities to get funding to do research. And I think this is the last slide. I would like to thank you for your attention. We are here to serve you at Sylvester. We are a big family, as you can see in that picture, and we are a family. We work together in pursuit of your cure and to try to make the lives of patients with kidney and other cancers better. Thank you very much.
And thank you, Dr. Mershon. That was a great talk, and we've already got some questions pouring in. Because there's so many people on the call today, I think it's best that if we start with asking the questions through the group chat. The first question we had was from Esther. She was wondering if you would be willing to share your PowerPoint with the people on the call today. Would that be possible?
I think we may. I will need to see if there's some information. I will need to review if there's any information that I may need to clarify, or I can check that, and I can probably give you a copy of the presentation later in the afternoon, and you can distribute.
And then Deb Maskins asked, she said, I understand Dr. Mershon has done a lot of research on minority populations, and she would like to know if you could please speak on how we can make sure that clinical trials include more minority participants.
That is a very important question, and I really appreciate that question. If we look at the numbers in the United States and research in general, minority populations are probably less than 10% of participants in clinical research. And in cancer research, clinical cancer research, is around that number and even more. And it depends on the demographics, on what minority population we're talking about. Sometimes there may be even less. And there are several barriers that we need to overcome in order to improve access to clinical trials in minorities. One, and a very important one, is education, okay? Informing. An informed patient is a powerful patient. Some of the barriers in that regard are like concepts or beliefs from patients' friends or from patients' families that clinical research is not worth it, that clinical research puts the patient as a guinea pig, which is, I really don't like when I hear that from other people or some patients' families, right? So education is important, and making sure that patients and families understand that clinical trials help cure cancer. That would be one first step. Second is improving access to clinical trials. For example, language barriers is another one. We always, at our institution, when we give information about a clinical trial, we always translate to here in Miami. I am in Miami. We have a large Hispanic population, so all of our trials, we are required to translate in Spanish, and we also have a Haitian population, for example. We translate it to Creole. And sometimes if patients have a different language, speak a different language, sometimes we need to talk to the ethics committee to create what we call a short form. So there are several barriers, but these are two very important barriers. And we are actually, now that we are an NCI designated cancer center, we are now opening other programs to improve even more access to clinical trials with minority population with several recently awarded grants that we have received to help minority populations. So this is work in progress, and we are dedicated to increase. That is a big priority for Sylvester.
Understood. And then Esther had another question. If we have a total nephrectomy, can we donate our kidney for research?
Well, in theory, yes. It would depend on where you have the nephrectomy, right? And like, for example, at the University of Miami, patients who have nephrectomy or who have cancer surgery in general, okay, in many subspecialties in cancer, the pathology department stores, the oncology department stores tissue for future research. Okay, so so patients sign a consent before surgery or during the initial evaluation that they would allow their tissues for further research. I say depending on the where you have the nephrectomy, because some hospitals who may not have the infrastructure to research may not be able to collect or to do that.
Understood. Gotcha. And then Andrea Levinson asks, can you please address the benefit of using Cirrus Data to target the correct treatment option?
Cirrus Data, S-E-E-R-S?
C-E-R-I-S is what.
Okay, so I think what Andrea is mentioning, this is a very, very large database that provides some information in terms of epidemiology, demographics, overall survival, but does not really provide details, especially with the newer forms of treatment. The way that we extrapolate, I would say, the data into patients is from either the individual large trials that are published or that are presented in research meetings, or sometimes we and others do a cumulative analysis of, let's say, 10, 15, 20 trials with one strategy or the other, and do analysis to see whether the trend of a specific strategy is towards improving survival or benefit or lack of benefit.
Corey Kettler asks, she's asking if you can tell us about results in Oncolytic Virus.
Yeah, so we have several trials of oncolytic viruses. One of them is in kidney cancer. We are still in the early phases. We are in the phase 1 trial, because this is a new viral agent in combination with some immunotherapy strategies. And we will have results probably early or mid next year. This is an international study, and in part due to COVID and restrictions using viral agents, it could have, we could have had results much faster this year. However, COVID has slowed things down, especially in trials with these agents that would require inpatient and protecting patients from exposure to COVID in the hospital and everything. So this usually the results are presented in the meetings, okay? The results are not ready yet. We have some interesting cases of patients who have had very, very good results. However, we cannot really generalize and say, this is the percent responses, right? So in order to give results, we need to use the scientific method to gather all the data, analyze, and then make conclusions.
Understood. So we've got a bunch of people thanking you for the presentation today, Mirshan, saying this was wonderful and that it was very clear, and thank you so much. And then Oscar B, do you recommend a certain diet while on treatment?
Diet. So diet is a topic that is gaining energy and power in the treatment of cancer in general, not only in kidney cancer. Most of the time when we discuss about diet in the treatment of kidney cancer, we discuss diet in the context of helping manage side effects of kidney cancer treatments. For example, there are some treatments that may cause nausea or may cause diarrhea or may cause altered taste. Okay, our nutritionists and some other specialists in nutrition give specific advice to try to change their diet in order to improve side effects. In terms of diet in the context of enhancing the treatment efficacy or modifying the treatment efficacy of A or B treatments, there are studies that are being done. However, I don't think to my knowledge, I don't think there's any study that has proven that diet A or diet B or a specific supplement or something is associated with improved outcomes in a patient with one or a different treatment.
And then finally from T.M. Murphy, he says, Dr. Mirshan, could you please expand on the comment experience counts in RCC, like from someone who has limited access to major institutions? For example, am I looking for an oncologist that treats X amount of RCC cases per year?
Mm-hmm.
Or
yeah, that is an important question. I always tell my patients when they ask about my experience, right? And I tell them, I give them a truthful answer. So kidney cancer is not a common cancer. It's 6 or 7 in terms of frequency of cancers. However, we are a referral center. I see probably 1 or 2 new kidney cancer patients per week, which is a large number if you compare to like smaller cancer centers or community centers where doctors may see 1 patient a year, or 1 patient every 6 months, or 2 patients every 6 months. So the experience is not only in the number of patients, but also in part the prior training counts, for example, right? Like is the doctor interested in kidney cancer? Is their practice focused more on cancers of the kidney or the urinary system compared to general, all different cancers, right? If they're in a bigger institution, do they do research in kidney cancer? Okay, and it is not wrong to ask the doctor, can you tell me about your experience in kidney cancer? Okay, honest, serious doctor is not going to feel insulted or won't feel bad if they ask that question. Okay, some doctors may be very sincere and may say, you know, I don't have a lot of experience and I would recommend you to see a specialist in kidney cancer.
Well, I believe that's all our questions for today. Thank you again, Dr. Mirshan, for coming and sharing your wisdom on all things kidney cancer. We've really appreciated it. Oh, Oscar chimed in one more time. Okay, last question, guys. We got, can you get IV vitamin C with these treatments?
Well, I have had that question for a few patients of mine, and there is no evidence. Unfortunately, there is no evidence that high dose IV vitamin C modifies or modulates the efficacy of any treatment or immunotherapy. There's a belief the notion that vitamin C helps improve your immune system, may help with the colds and everything. However, in terms of like enhancing the effects of immunotherapy, there are some studies that are being done with high doses of different vitamins, not only vitamin C, but different vitamins, right? That are being conducted right now at the studies. So until we have the results, we cannot, me as an oncologist who sees kidney cancer, I cannot condone or say, you know, yes, it will help or not help. I usually do not recommend because there's no evidence. We, like the oncologists who do kidney cancer research, we always try to look at the evidence from studies that are published and reviewed in order to make conclusions.
And the moment that that information becomes solid and they've been able to reproduce positive effects with that, you will certainly hear from that story being shared within the Judy Nicholson Kidney Cancer Foundation social media and on our website. We do have another one of these talks coming up on September 2nd at 1:30 p.m. Dr. Naomi Haas and Deb Maskins, who is a patient and also the founder of KidneyCan, will be able to answer your questions. Sorry, Kidney Cancer Canada will be able to answer your questions, and they're going to talk shared decision making for kidney cancer patients. So please, if you haven't already, you can go to our website and register for that event, or you'll also find a link to that on social media. Thank you all for joining us today. If you're interested in checking out this video, it will be on our website and our social media tomorrow by noon Eastern Time. Thanks again, everyone, and I hope you have a great day. And thank you again, Dr. Mershon.
Thank you very much. Have a great day.